Thank you all for being here. Is Dr. Professor who is a professor in neurosurgery and head of the Department of Neurosurgery in University Hospital of Thessaloniki. He's going to talk about the pediatric brain tumor surgery. Where do we stand? I think we have heard a lot about radiation oncology, so we need some surgery now, okay?
Okay, so thank you, dear chairman. Thank you all for being here. Welcome to Thessaloniki. So I'm working in Aristotle University Medical School as a neurosurgeon, and we are not talking about radiotherapy anymore. But I would like to thank you for being interested in pediatric cancer, which is a clinical problem for us. And my task today is to talk a little bit about this organ, which is quite different from the others. And speaking about the pediatric population, has a lot of vessels, interconnections, there is neuroplasticity, a lot of photoregulation systems, and the mechanical resistance is very low. So it makes a difference when we apply our treatments, either surgical or radiosurgical or even drugs. So where is the problem? Pediatric brain tumor is 25% of pediatric cancers, but they have a high mortality and morbidity. They are responsible for 39% of cancer deaths. They're the leading cause of pediatric cancer death. We have a lot of neuroradiological advances last years. It is great. We have early diagnosis, and this is very important. I'm going to talk about that a little bit later. Surgery, what we are offering, 3 pillars. Biopsy, it is important in our precision season. We have molecular subclassifications, brain relaxation, so relief of symptoms. And the third one is the cornerstone of oncological treatment. So the next one is pathology and molecular, chemotherapy and immunotherapy. We have other speakers about that, and the radiotherapy I'm not talking about them. So in 2021, we have the 5th edition of what is the new classification. This is my 3rd adoption in a new classification. So it is very difficult now to accommodate all these molecular subtypes, but they are important. And basically, in the pediatric population, we have 5 groups. You have to know the low-grade ganglioneural tumors. Radiotherapy has to do here. The high-grade, of course, ependymal tumors, embryonal, and mesenchymal tumors. On the right corner, you can see 4 different subgroups of medulloblastomas, a very common pediatric tumor, dependently on the molecular basis. They have different prognosis, different treatment. What about infratentorial, supratentorial location? Well, it depends a little bit of the age. In the blue lines are the infratentorial. So even with the new classification, it doesn't change a lot. This is the most important slide of my presentation, neuro-oncological balance. What is this? So from one side, we want to take the tumor out. We have to increase our resection. More we are taking out, better your job will be. This is true, and better will be the outcome. But on what depends? On the other side, it is the neurological outcome. As I said, we are in a very, very sensible tissue, and it's not like the liver, for instance. And third, what is important is to not add side effect from our treatments. This is extremely important. It has been mentioned before. It was a problem with radiotherapy for many, many, many years. So the importance of degree of resection. This is some graphs that you have to be accommodated. So this is the time, this is the survival. So at the beginning of diagnosis, everybody is living, all right? But on the road, you are losing patients, and you can see that this curve with a complete resection do much, much better than partial resection. And not only that, you can see that there are more long survivals with complete resection. So resection, degree of resection is important. And this is true for all ages. And you can see that biopsy, this gray color, is maybe in the first year more important, but then it's a little bit not popular, and we are going to more and more resections. So how we can do that? How we can arrive? What are the tools we are using? So one thing is, as I said, neuroradiological achievements, advances, and one of those is resting state fMRI that can be applicable to the pediatric population, because we don't ask the patient, to the young patient, to perform a task. So I don't want to go to the details of that, but it gives us a little bit the network of the brain and when we can from where we can reach the important places. Like in this example, for instance, this is a tumor, this is an area, a hot area that we can now go through that, so we can choose our approach, we can do a 3D model, avoid the vessels. All these are very important structures, and we can even go deeper in the diffusion tensor imaging, so we count these facts. This is our important tracks, and we can choose the angle not of our field, but of our knife. We have neuronavigation that help us a lot, and so we can be guided in the navigating into the brain. And speaking about the evaluation of the degree of resection intraoperatively and not postoperatively, but intraoperatively, we can use intraoperative MRI, not in all places, not in all centers, but in all centers you should find intraoperative ultrasound, which is extremely non-expensive, but the quality of image is great. So you know that this is the tumor, this is the sulcus, this is the normal brain. We have more tools. What are the tools? So under the microscope, the tumor or the white matter is white, but if we remove a porphyrin, so this is the 5-valent technique, you see that under a special filter, the tumor becomes purple. So we can see the tumor under the filter, and we can take it out again under the white microscope. It's just as the same as the rest of the brain. So what is the morbidity of what we are doing in neurosurgery in this population? So this is a large cohort from Liverpool. I like it a lot because it's some 364 craniotomies for a brain tumor in this population. And the two major problems are CSF that we need is infections. So I would like to show you a little bit two things about that. What is the neurological about? This is the total number. I'm going to talk about the neurological deficit, but first I'm going to talk a little bit about CSF leak. So once the CSF is in contact with the skin, we have all these germs in our hospital, and then start the problem with infections. So we can do different things. Everybody who is treating a patient should wash their hands and do also different strategies that we are doing now, like surveillance, like following guidelines, and this is a very important thing. Let's go to the neurological outcome, what you can do to avoid problems. We're doing a lot of electrophysiology intraoperatively. So we are applying currents on the brain. We have it in front of us. And we are recording like an EMG. It's as simple as that. So if something is going wrong, then we stop. So if we are losing our EMG, then we stop the resection, and then if we are waiting a little bit, the NPs will recover. Why is this important? Because look at the graph again of survival, the Kaplan-Meier graph. So this is extent of resection more than 95%. We said that. This is extent of resection, the green one, less than 95%. 95%. But look at the blue graph. So this is deficit. So if you have a resection, but with neurological deficit, you go as bad as less than 95% last subtotal resection. So it is very important. How often this happens? Well, a neurological deficit after surgery is an event of around 10%. But hopefully in 30 days after surgery, most of them, 80%, will be resolved. So finally, after 1 or 2 months, or only a very small portion of this population will have a permanent deficit. What about the operative neurological deficit? Do we have an impact of that? Yes. So in 30% of them resolved, and in another 30% they improve. So something we are doing. I think I'm not going to spend more time on that. I'm sure that you are aware about the problems of the treatment side effects, and that this population has poor psychological well-being, and the quality of life is not good when you add side effects. I'm going to spend few words about craniopharyngiomas, because it's a special problem in this population, and even in these huge craniopharyngiomas, you can do good resection. The problem is not the degree of resection in craniopharyngiomas, but the side effects of surgery or of radiosurgery, which is the hypothalamic problems. And so the last 20 years, there is a shift to more conservative resective strategies, and even the radiotherapeutic treatments are more gentle with hypothalamus, and then the results is much better. So we have to take care before surgery. Where are the mammillary bodies? When the mammillary bodies, a very easy way to see, goes up, then probably the craniopharyngioma is pushing up the mammillary bodies. When they look down the mammillary bodies, then probably they are already in the hypothalamus. And this is the last special problem I would like to talk with you, which is the incidentalomas. We are doing more and more MRIs in this population, and we come out with this kind of findings. So completely asymptomatic, no neurological deficit on clinical examination. What we should do? Well, this is the reasons for primary imaging. You see trauma, headache are very common. So more and more children are coming to my office for headache. I don't know what is happening. And then you come out with this kind of lesions, and you are saying, okay, this is not probably the reason of headache, but what I'm doing with the lesion? Well, you can wait and scan, and it is scanned that if you see a progression at one point, you can act, or you can do a biopsy to be sure that what you are dealing for, you can resect it, or you can do upfront chemoradio. Well, there is, of course, the risk of biopsy or resection from one side, and the risk of malignant transformation and the change of growth. And it has changed late years, 2 3 years ago in our community. So if the lesion is accessible, we believe that the surgery is low risk and we should go for resection. On the other hand, this is not always the case. And in some deep locations or eloquent areas that we can know from preoperative neuroradiological imaging, then we are waiting and watch what is the progression. We have multiple sequence of the progression, and at that point, we know that we should do something. So there are still some non-answered questions about the case, and I will come to my conclusions because we are running late. So maximize efficiency is very important in this neuro-oncological balance, but with safety. And the most important for this population, for the treatment of the children, is collaboration. And I believe that this is exactly what we are trying to do this very nice afternoon, Saturday afternoon in Thessaloniki. Okay, thank you very much. I'm happy to answer any questions.
Thank you very much. You said a lot on the 15 minutes, but just one question or one comment if someone wants.
Just one more minute, please.
Yeah, here closes the session in this room, but I just wanted to remind you that in the main auditorium, Professor Roberto Orecchia and Arnold Campos are giving a presentation in the framework of the Aristotle Medical Forum in the session of the role of artificial intelligence in radiation therapy. So I encourage you to just step in the main auditorium. Thank you very much.